Good morning, everyone. Welcome to I think this is the eighth or ninth module of a series of webinar between the Philippine College of Physicians and the Department of Health. So our topic for today is real experience and best practices improving outcomes for COVID-19. So for the webinar house rules, please mute your mic during the webinar to minimize background noise. Send your questions by chat in Zoom or Messenger or on FB. Send-in questions will be answered at the end of the presentations by our three speakers. So the recorded webinar will be available at the following Facebook pages: Department of Health, Philippines, and the Philippine College of Physicians. So today, we are proud to announce that we have three speakers for today. One to share their real experience and best practices in improving outcomes for COVID-19. So the general objective of this talk is to share the experience and best practices in handling COVID-19. Specific objectives is to narrate the preparations made to handle COVID-19, to describe the holistic approach in managing COVID-19, to discuss the rationale for the different interventions given and explain how the patients were monitored, and to explain the ways to sustain the effective measures to improve overall outcomes. So we have three institutions that will share their experiences and challenges. There are three institutions. One institution is a regional general hospital and regional hospital. The second institution is a COVID referral center. And the third institution is represented by a private hospital. So in order of presentation, I will introduce our three speakers and presenters. Our first speaker is Dr. Glory V. Baltasar. She's the Medical Center Chief 2 of the Bataan General Hospital and Medical Center. She did her Master's in Public Health as well as a Master's in Hospital Administration at the University of the Philippines, Manila. She's a Lingkod Bayan Awardee of the Municipality of Orion and a Lingkod Bayani ng Bataan Awardee. Our second speaker is Dr. Eileen Aniceto. She's the Operations Coordinator of the Incident Command Structure for COVID-19 at the Lung Center of the Philippines, which is one of the COVID referral centers here in NCR. She's also the OIC Department Manager of the ER and the Outpatient Department of the Lung Center of the Philippines. She's a board member of the CHEST Philippine Delegation and is a treasurer of the Philippine College of CHEST Physicians. Our third speaker is Dr. Benjamin Campomanes Jr. He's the Executive Vice President and Chief Medical Officer of the St. Luke's Medical Center. He was an associate professor for 25 years at the UST College of Medicine and Surgery, as well as the past president of the ASEAN Rhinologic Society and Philippine Academy of Rhinology, and a past board member and examiner of the Philippine Board of Otolaryngology, Head and Neck Surgery. So we welcome our first speaker, Dr. Glory V. Baltasar, to give her talk on their experience in the Bataan General Hospital.
Good morning, everyone. Can you hear me clearly? Good morning. So, thank you, PCP, for inviting me in this forum. I would like to acknowledge the PCP members of our institutions who still continue to take care of our COVID-19 patients, as headed by our department chair, Dr. Brian Ilagan, our IDS, Dr. Ann Chan, pulmonologist, Dr. Ronquillo, cardiologist, Dr. C, and Dr. Sibilia. And of course, all of our medical specialists and medical officers. Thank you for your team effort. My profound gratitude goes to all of you. This is the outline of my presentation. I have been in public service for about 27 years, and this would be my most unforgettable year. BGHMC is the only tertiary level 3 hospital in the province. It is a DOH. It is a DOH level 3 retained hospital, licensed for 214 beds with an implementing bed capacity of 500. During ordinary days, our occupancy rate is about 200%. Our hospital lies in the city of Balanga. We are a first-class province of about 800,000 population. In the province, there's only 8 private hospitals, 2 of which are level 2, 5 government hospitals, 19 rural health units, and 195 barangay health stations. The background of our experience. The first COVID-19 patient was admitted sometime in April 6. We started our COVID-10 TRIAGE setup in front of our hospital on March 6, 2020. Our first COVID patient was admitted on March 13. He was asymptomatic, but it so happened that he was the roommate of an index case, a professor coming from Manila who went home due to symptoms of referable to the respiratory system. He was admitted in a private hospital in our province. And this index case in our hospital is a known roommate, so he voluntarily have himself checked up in our hospital. Succeeding days, we have 5 confirmed positive COVID-19 patients. On April 1, 2020, an emergency wound exploration of hacking wound patient done by our COVID point person, also a trauma surgeon, was done. It turned out that the patient, that hacking wound patient, was positive on PCR. The result was released on April 5, 2020. On April 6, all involved in the surgery were tested, and our trauma surgeon turned positive. Result released on April 10, 2020. Being the index case, her close contact were all tested. On April 16, 2020, all hospital employees at that time, there were already 16 3 consecutive days who yield positive for the PCR COVID-19. All were admitted regardless of their symptoms and category, and mass testing commenced. So we did a root cause analysis on the increased healthcare work infection. We considered the 4 major areas where possible causes of infection may have come from. We considered the materials, Mother Nature, manpower, and methods. For the materials, we saw that the scarcity of the availability of PPEs at that time could have caused, and of course, the poor quality of some provided PPEs. Second is the prolonged usage of PPEs. Third, inappropriate donning and doffing procedure. fourth is the misleading guidelines on the use of PPEs. When it comes to the environmental factors, the patients and other stakeholders, we saw that there was non-disclosure of patients' travel history and or exposure. There was also that denial that they did not disclose their symptoms. And in a government hospital, an uncontrolled movement of watchers and visitors is quite a dilemma for us. Of course, every one of us lack awareness on COVID-19. For the third factor in analyzing why we had this outbreak, the manpower. Our healthcare worker could have acquired community-acquired COVID infection, could be attributable to traveling and public transportation. Number three, other hospital-acquired infection. Some of our healthcare professionals engage in private practice in other hospitals. And of course, breach in infection and prevention control. And there was no strategic workforce and response team for COVID-19 patients. And the fourth factor in analyzing this increased healthcare work infection is on the methods. One is the delayed in PCR result, insufficient infrastructure of facilities for pandemic such as isolation rooms, and the no zoning. The health facility outbreak management. To start with the situationer at that time, April 16, 2020, there were 16 employees positive in just 3 days. That moment, 216 inpatients are being handled in the different wards, of course with 216 watchers. 500 outpatient were registered at that time. And there were 600 employees who were inside the hospital at that moment. Likewise, as I have mentioned, our facility is not prepared to handle such surge of COVID positive patients. So that moment, there were only 30 isolation rooms, our private rooms. We converted it immediately to isolation room. 70 identified beds for positive ones and 8 ICU beds for severe or critical ones. And the dilemma at that time was there were still non-COVID cases admitted in the wards. So how did we handle the situation? We quarantined all employees that were inside in our hospital at the time of the recognition of the problem. We immediately implemented the quarantine house rules, which we used in the repatriation of OFW in New Clark City. Re-stratification was also used in cohorting the employees, in housing them inside our new buildings. We immediately converted our 5-story building to become a quarantine facility. We did mass testing with high-risk prioritization. We isolated and identified the symptomatics without PCR and treat accordingly. The province was already prepared in handling the mild PUIs by putting up CCTV, and we monitored them as in the setup of Pinoy Big Brother setup. We admitted those who turned positive in a cohort and revisited those. We assigned doctors to revisit the clean cases in the wards and facilitate if they can be easily sent home, or those who are still needing management, they have to be kept in a green zone or isolated for the infectious one. Also, we crafted a step-down protocol for the asymptomatic, and this was implemented on the latter days of this pandemic. Other measures made were we repurposed, reassigned manpower to other areas, like the physical therapies, occupational therapies. At this time, they do not have patients, the dental section, and other administrative officers and administrative manpower with registered nurse licenses were pulled out and augmented in areas where manpower is lacking. So we have a skeletal workforce and we did job rotations. We immediately activated our incident command system, for which we have a team trained on this. A task group was immediately created in order to optimize our operation on COVID-19 as is spearheaded by the medical center chief as the responsible officer. So our operations on a day-to-day basis is more on having a daily objective on what to address on that particular day. So the matrix presented is the composition of the officers that we have designated for different factions that they have to uh, be in charge of. Likewise, the Bataan Interagency Task Force designated us as a referral hospital for COVID-19 cases in the province effective April 17, 2020. During this time, we conceptualized 6 objectives in handling COVID-19 cases during this period. One is to provide quality treatment for all BGHMC employees and patients who are afflicted with COVID-19. Second, control transmission within BGHMC. Third, control transmission outside the hospital. Fourth, operationalize biosafety laboratory 2 or PCR laboratory. Set up an annex at Capital Compound so that we can still continue to handle patients who are considered non-COVID. And of course, we have to continue the residency training program. For our objective number 1, in providing quality treatment for all our employees and the afflicted patients. Sorry for this slide. This is quite a busy slide, but let me walk you through this. We have a total of 101 affected employees. So, tawag sa amin ay COVID-101 na kami. Currently admitted, we still have 19 on their way to recovery. We were able to discharge 73. 9 are currently brought to our step-down facility, but we ask them still to have their monitoring. For the asymptomatic, majority of our healthcare workers are in the asymptomatic category or classification. 93 of them are ranging from mild to asymptomatic, moderate 4, and severe 4. This is the profile of our employees. Most affected division is the nursing service, followed by the physicians. The length of hospital stay of our employees range from the shortest 5 days and the longest 35 days. Shortest 5 days, upon recognition that they are positive with COVID-19, they were immediately admitted regardless of their symptoms. And after that, since the delay of the PCR result contributed in leading us to the diagnosis and management, so when they get 2 consecutive negative PCR, we discharge them and bring them to the step-down facility. For our non-employee patients, we were able to admit total of 36 patients. So currently we have 5 adults and 1 pediatric case. We're able to discharge 23 cases and 6 are already brought to the step-down facility. For the non-overall admitted positive cases, we have 137 and we only have 1 mortality, a severe case of pneumonia. So this is the length of hospital stay of our non-employees. Shortest 1 day, this is the case of our mortality, longest 48 days. This is the protocol in admitting COVID-19 positive patients and employees. Upon admission, this is the diagnostic tests that are requested by our team. It is a team approach. I think this is a major it's a good practice that upon recognition that members of the hospital workforce are affected, immediately the team approach was in effect. If on chest X-ray or CT scan the patient has pneumonia, antibiotics will be given, usually ceftriaxone and azithromycin. Likewise, the X-ray is being requested and for 3 days for stable patients to monitor status of pneumonia or earlier if the patient deteriorates. Patient will also be referred to infectious disease specialists, cardiologist if hydroxychloroquine will be started or if patient is high risk. So they will be given lopinavir or ritonavir if the hydroxychloroquine will be a contraindication. Other medications given are zinc syrup, vitamin B, and multivitamins. This management of patient with probable or confirmed borrowed from the Philippine Society of Microbiology and Infectious Disease Specialists. We did not totally adhere on this protocol because as we take care of our employee, we want to be responsible in taking care of them. Ideally, the PISMID recommend that those with mild or low risk, they should be brought home or for community isolation. But since we feel responsible and we want our employee and people know that we will take care of them, we still opted to admit them in the hospital for proper monitoring and caretaking. As you can see in my previous slide, the majority of our employees were asymptomatic. 93 of them were asymptomatic. Moderate, we admit, and so on and so forth. Our protocol in discharging our COVID-19 positive employees, there should be clinical resolution of symptoms and 2 negative PCR results with at least 24 hours apart in doing the swab. The employee can return to work after having 2 negative results using the RT-PCR. The recovered employee can be integrated back into the community to fulfill his duties as a responsible Filipino citizen. How did we, for objective number 2, how do we do controlling of transmission within BGHMC? We implemented quarantine protocols. We designated a lead quarantine officer and quarantine point persons for housing area occupied by our employees. All employees has been temporarily accommodated at the new OPD building, a 5-story building, and some identified hotels near the hospital. We required all employees to wear appropriate PPEs inside the hospital premises. We limited their movements, and we also implemented the quarantine protocol used in the new Clark City. Second measure, we identified the symptomatic employees and see to it that self-monitoring of temperature and respiratory symptoms were done for 14 days or more. Another measure is we did mass testing so that we can categorize who are the ones who are negative and the ones who are positive. After 7 days in the red zone or in COVID wards, nurses and doctors, even during this time, belonging to the high-risk category, were tested in every 2 weeks for the low and medium risk categories. And we waited for the result prior to sending them home. PPE protocol, the paging system in our hospital, most of the paging will be donning and doffing officer being called in red zone. The health workers should don and doff PPEs only with the supervision of the designated donning and doffing officer of the ward. And we are really very strict on this. On the right side of the screen is, I borrowed this from the presentation of our IDS, Dr. Ann Chan, during the webinar, wherein the hierarchy of control for infection prevention is being observed. So as you can see from this inverted triangle, PPE has the least effective control in infection. But we can say that from PPE use, administrative control, engineering controls, and substitutions, we all use this. At this point, we can really say that it's really hard to eliminate the virus, even if in our setup, all areas undergo three-stage decontamination, especially when patients are discharged. So we are all employing these measures. Other measures, we do frequent hand washings. Our engineering area constructed shower rooms for our utilities, janitors, and the maintenance people. And our disinfection protocol is more stringent. Of course, we have to provide, still being a government hospital, we still have to continue services for our special cases. Our new triage area is a blue mid tent with, equipped with negative pressure. So we can triage our patient there. And trauma cases needing emergency surgery are also done in that blue med negative pressure equipped facility. Hemodialysis patients, we divided our area for green zone for non-COVID and red zone for the confirmed one. Cancer patients still continue to receive their chemotherapy in a coordinated off-site venue. We have a zoning in the hospital for the red zone, yellow zone, and green zone. Red zone is considered the hot zone where infectious cases are confined. All medical professionals shall be in full gear, medical and allied professionals. Type A PPE, proper donning and doffing protocol is strictly observed. For the yellow zone, which is considered as the intermediate zone or the caution area, has a 6 feet radius from the identified red and green zones where linens and food are regularly delivered and collected. The green zone is considered as the clean zone, which includes admin offices. These areas are considered safe, however, healthcare workers shall be in type B PPE. This slide shows how we zone our hospital. This is our blue med tent. This is where the patients will enter. They will be triaged here. If the patient is admissible, patient will be brought here for admission by our ambulance. This is our isolation rooms, 30 isolation rooms. And it needs cohorting, they will be brought here by an ambulance. This is our hemodialysis units. There's a separate entry for the confirmed cases and a separate entry for our non-COVID cases. Initially, this is a no entry zone for our employees. This is the 1.2 hectare parking space. Now, this is the entry for our all employees, and this is for the patient's entry. So this is the quarantine facility. Our 5-story OPD building is where we quarantine some of our employees. This is the location of our PCR lab on this side. The control of transmission outside BGH, we see to it that risk categorization is in place. Low-risk employees are employees who have no patient contact, no known exposure to probable or confirmed COVID-19, and these are the employees who continue to work in offices. The medium-risk employees under this category are those employees without patient contact but are actively involved in the task force duties. They can enter into yellow zone. High risk are employees with direct patient contacts and with exposure to probable, suspect, confirmed COVID-19 patients, and who go on duty at isolation room for suspects and COVID-19 ward. Of course, other measure that we have implemented is we temporarily suspend the private medical professionals outside the hospital. Tested in the whole province of Bataan. And this is the number of employees that tested in our hospital, 109. 45% of the overall tested individuals in the province came from BGH. Number of confirmed COVID-19 in the whole province is 159. The reason why it separates at the provincial health office, they do not include our doctors who are coming from outside the province. But I included it here. So it is impaired for is 93%. Total number of recovered cases in the whole province is 100. It's included here, so 96%. Mortality for the province is 7. In BGH, only 1, which is 14%. We have an ongoing installation of the negative pressure, positive pressure in our biosafety laboratory. It is expected to be operationalized by June 2020. However, our expert already stage 4. We're still waiting for parts to be delivered in our facility. And 5, though we classified as or considered as a COVID-19 referral hospital, to find it very difficult for our indigent patients to for the cases. So we requested the province to allow us to use their old building, the old capital building, which is supposed to be converted into a museum. Some minor repairs. We removed the cubicles, partitions, and comfort rooms are being constructed. It's soon to be operated by the beds for the OB cases, pediatric cases 10, IM 10, and surgery 10. This is the distribution of the main BGH accommodation for our COVID cases or suspects. 70 isolation rooms for our severe and critical suspects, and 30 beds for the positive one. Our admission criteria for our clinical department is that they included the PCR result as the key in the admission for the non-COVID cases. So no PCR result, no entry in the non-COVID case. We are optimistic that this can be realized, considering that we are about to receive our gene expert machine. We continue to provide services for our patients through teleconsultation. Of course, number 6, we still continue our residency training programs. The Department of Medicine and our other departments still provide webinars for their medical officers and medical specialists, as well as the recent webinar provided by our infectious disease specialist focuses on COVID-19 so that awareness will be enhanced even among non-doctors. And what are our ways forward? Of course, we really have to minimize face-to-face contact. So we have to strengthen the SDN online referral system from the province. Way back 2018, we started our online referral system. All rural health units and district hospitals are connected to us. They refer their patient to us through this online referral. And it's now being provided with bed trackers so that patients will no longer be brought to us when they can access if there are still available beds. And since November 2019, we're already using our electronic medical records. So no paperless documentation is already in place at BGHMC. Of course, we really have to closely coordinate with our private practitioners and lower healthcare facilities. And continual improvement and stringent measures for infection and prevention and control should be implemented at all times. And we should invest on facilities, equipment, and people. I think this will be my last slide. Unless commitment is made, there are only promises and hopes, but no plans. Thank you very much for your kind attention.
Debbie, should I dive right in? I guess I should dive right in. Hello, Debbie, Dr. Ona.
Yes, ma'am. Thank you, Dr. Baltasar, for sharing your experience and your initiatives. We go to our next speaker, Dr. Aniceto from the Lung Center of the Philippines.
Okay, good morning, everyone. I was given 2 days to prepare for this. But we have a ready-made lecture because we've been doing this promotion for at least our best practices for past quite some time. So it's easy to just modify the slides to your requirements, right? So Lung Center of the Philippines, you know where we are, the Quezon City. We're the premier institution for lung and chest diseases, providing quality healthcare. And since the start of, since the start of the COVID pandemic, we have been designated as one of the 3 referral centers for COVID-19, specifically catering to patients with moderate to severe respiratory diseases. When we started, I'd like to show you our bed capacity when we started. We had 8 isolation units that we admit patients with airborne conditions. And we have another 192 for private and service patients. We have a total of around 200 bed capacity. And just to show you how we progressed over time, we needed to convert most of our rooms. Actually, at present, we have 89 isolation rooms dedicated to COVID. But remember, we're not a pure COVID hospital, and we had to keep our services open for our cancer patients, for our patients with COPD and asthma. So we're not completely COVID hospital. And so we maintain our designation as a referral hospital for moderate to severe patients with COVID-19. And our first response, as should any government hospitals, would be to shift to an incident command system. And the objectives of which would be to prepare for the surge of referrals, to prioritize health personnel safety at all times, and to improve our patient monitoring system. Dr. Baltasar already showed how an incident command system looks like. We just filled it up with our names, and then we designated people in each of the tasks. The operations are meeting. I don't know if it's being done all over, but as far as Lung Center is concerned, we have daily meetings for the past 65 days in this outpost. And every day, including weekends, we meet and update each other on what's happening. This is our typical board, and you can see our discussion moves from right to left, and we discuss everything, and everyone concerned from each of the operations is privy to this, and so no one gets left behind. Okay, so the bulk of the work falls under the operations, of which I am the coordinator, and we're divided into task forces, strike teams. We've had to stop services for some of our elective procedures, OPD service, our private clinics were stopped 2 weeks into the lockdown, and all of the other services were offered on a limited basis. And our priority in each of the task force has always been personal safety. So we made sure that we had enough PPE for everyone. We made infrastructure adjustments so that zones are delineated properly, and of course, modified our rooms so that we can improve on patient care. Of course, medical management, all of the hospitals, we have this in place. It's just a matter of implementing it, following guidelines, and making sure that our patients are monitored properly. So personal safety, okay, if you don't recognize me, that's me. And when this picture first came out on FB, naawa yata yung mga tao sa amin kasi we were using a plastic garbage bag to augment our PPE. But from then on, we got donations. And at the present, we have isolation gowns, enough for 95 days. We have coveralls, enough for 114 days. And 95 masks for all of our staff for 39 days. KN95, 100,000+ pieces. And raincoats that will last us for 74 days. So it's a lot. It's a moral boosting for our personnel that they know that we will not run out of personal protection equipment for them. We also very early on emphasized safety zones. You all know this, and we have rules what kind of PPE should be used in each of the zones. And we went, well, I guess you all did this also, made sure that there are signages all around assigning the rooms. I'd like to point out that in Lung Center, we do not have a green zone. We have a no mask, no entry policy. And we have a separate entrance for the personnel. And they have clear instructions on which pathways to use so that they never have to cross a designated orange or red zone for non-medical personnel. And going into the clinical areas, there are signs all over the place to remind everyone what zone they are in. So this is how we delineated our safety zones. So at the ground floor, my pointer is not acting. Okay. Anyway, the blue zones are more or less the administrative side. The yellow zones, that's our X-ray. So only when they're patients, they need to dress up. They have designated areas for COVID patients and then a different pathway for non-COVID patients. The orange on one side is actually red. That's our clean ER red zone where we see non-COVID patients. And you will see that each of the floor has clearly demarcated zones, and that warnings are posted at the beginning of each zone so that none of the personnel will enter a zone with the wrong kind of PPE. And of course, we have a very active safety officer. And aside from checking that all of the zones are properly observed, he has safety reports and incident reports and near-miss reports every week and as needed. And let me talk about the triage, because I think we have one of the best systems, and I will show you why. Our objectives, as for all our task forces, is personal safety, and of course, secondly, is to improve patient care by improving infrastructure and improving process flow of patients. So this is in the early days, around mid-March, okay, the first week of the lockdown. We couldn't bring our patients in the emergency room, so we had to make a makeshift emergency room outside. so that anyone entering our institution have already been screened. Okay, so we have a triage system under a tent. We had to make we call it a dirty ER for resuscitation of COVID suspects, and we have tents all over the place for waiting areas, and we brought out our swabbing tent as well, so that without having to enter our hospital, we were able to screen and the cohort patients or identify COVID suspects. Now, we were lucky because last year we started building our outpatient complex, supposedly for our service patients. And it's situated in front of the main building near the emergency room entrance. And so we needed to convert the entire OPD complex. So you see it's open air, we have a room, it's very well ventilated. And so we designated a resuscitation area, which on your screen you will see as red. And we designated the OPD COVID consult in the orange zones. And then a yellow zone is our outpatient lab with a negative pressure to protect the medtech. And we devised a system of screening. Even before the patient enters the complex, there's a screening tent will screen patients whether they're for COVID triage or whether they can be immediately brought to the clean or the non-COVID ER. But largely, since we're the lung center, all of the patients consulting, whether COVID or non-COVID, have respiratory symptoms. So what happens is majority of our patients really gets screened in the triage area for COVID. And this is even before anybody gets or enters the hospital proper. The blue zone is where the personnel. So I'm sorry for that. Okay. The blue zone at the back is where we place our donning tent for patients. All patients entering our complex should be done fully. And then we have a separate doffing area. Okay, so this is the triage donning area immediately before the complex. And then this is the triage doffing areas, which is located at the exit points of the complex, right? Of course, there are instructions what to do inside the tents so that they don't forget the procedure. Okay, and there's only one exit. So you enter one side of the tent, you doff, and then you exit on one side, and then there should be a disinfecting area and or a wash area when you leave the doffing tent. So the advantage of our triage complex is that it's self-contained. All the services that we need to resuscitate, to diagnose the patient is available. We even have the social services, the cashier, and this box which we need to record patients in is there. And the patient only leaves the complex two ways. Either they get discharged, or they get admitted. And we have a separate entrance for patients requiring admission from the triage to the hospital proper. Okay, and the medical task force actually takes the heaviest load of all the task forces. But again, you will see that our priority is personal safety. And so we modified our infrastructure to ensure that and to improve patient monitoring, because each of our rooms are not equipped for an ICU setup. And so we had to convert a lot of them, putting in cardiac monitors and a CCTV system so that the patients can be monitored even if there are no staff inside the room at all times. And of course, shifting from a non-COVID hospital to a COVID referral hospital, we needed to increase our bed capacity fast. And most of our infrastructure modifications consist of, like I mentioned, putting in CCTV in areas where we cannot physically visualize the patients, putting in patient monitors on rooms that we've converted to ICU or a critical care unit, translucent doors for easy visibility of patients. For all our rooms, we checked the air exchanges. We changed exhaust systems to ensure our respiratory exchange rate of at least 12. And so for all our designated COVID rooms, we've been successful in assuring that at least the air exchange rates were acceptable. For each of the ward, we have designated donning and doffing areas, and we made sure that they are not in the same area to avoid, of course, cross-contamination of clean and exiting dirty personnel. And so this is what we did. This is an example of our ward. And so the blue is the entry. So these are two separate wards that we've converted to COVID isolation rooms. At the entrance of the ward is the donning area. We've designated a room for that. And in the entire time that they're in the red zone, they do not take off their PPEs. Now, each of the rooms will have additional donning of a plastic overcoat or a raincoat or what we used before as a trash can if they need to do a procedure to the patient for added impermeability of their PPEs. And then the designated doffing area is at the other end of the ward, and only if they're ready to get out of their PPEs. And then they have to go about the long way for them to enter the complex again. Right. So if they need to use the restroom or they need to eat, they have to doff, leave the complex, do whatever it is they need to do, and then don again before they enter the complex. So this is an example of the entrance. Aside from the doors, we put plastic curtains, which unfortunately at this moment is starting to deteriorate. That they're due for replacement. This is an example of a donning area. We've converted one of the private rooms to serve as the donning area. And this is how a typical ward looks like, right? So the plastic wall on the right is just to separate the patient entrance from the personnel entrance. Okay, and all of the additional gloves or disinfecting solutions needed after leaving every isolation rooms are located outside. And we have, you can see, designated trash cans in each of the area. Okay, so these are just some of the other shots. And then for the ward rooms that we've converted to critical care units, we have patient telemetry. So this is an example of how we converted one ward and put the patient telemetry in a separate room for nurses and doctors to monitor. We had to put in CCTV. Of course, patients or the relatives are warned that there's a CCTV so that we can actually monitor if there's anything happening to the patient. For our ICU, we've completely moved the nurses station out of the ICU and put it outside with, again, plastic divisions. Since this area has no windows, we have HEPA filter to make sure that the area is clean. All right, so this is where we place the new nurses station for our ICU. The ICU is in the ICU beds are inside, okay, and all the monitoring systems are placed outside. So this is a yellow zone, and the nurses need not be on full PPE when they're in this area. And then, of course, we have a donning and doffing area for our ICU. Okay, so you can see there the ICU patient inside and the nurses are outside. Of course, you will also see that there's always one personnel designated to stay inside the room, 1 to 2 personnel at all times. And the rest of the nurses and doctors are outside. They only need to don and go in case of emergency. Okay, so even our diagnostic areas have separate entrances for COVID suspects. So there's no mixing. Of course, since we're getting our rooms ready for the surge, and we're particularly getting ready for moderate to severe patients in respiratory failure, we needed to increase our ventilators and our patient monitors. So we're very thankful we have donors for most of this. We needed to buy also to augment, but between the donations and what we're buying, we should be ready for any way that COVID is gonna send our way. All right, so our day supplies, like I showed you, we've been stocking up, and we're ready for the next 3 to 4 months. We've converted parking lots to accommodate our area, our bodega. Okay, and then of course we take care of our healthcare personnel. Aside from providing shelter, food, we provided transportation, and we've also tried to provide psychosocial support for personnel who require it. Okay, so these are some of the temporary and semi-temporary shelters that we were constructing in our grounds. So some of these are in use already, some are still being constructed. And of course, especially in the early part, we get a lot of donations. So again, thank you to our donors for donating food for our frontliners. Nakakataba ng puso for our frontliners that, you know, people show they care. And we went on one step further. This is, I think we're 4th or 5th week into the pandemic and the lockdown, and a lot of us didn't have any manicure or haircut. So, you know, we got this group of beauticians, we equipped them with PPE, and then we offered a 3-day feel special day for our personnel. So we are proud that we've had at least 30 days of COVID-free streak, as in the whole month of April. This is our number of our personnel in the clinical areas, about 400 plus, in the non-clinical, about 300. And we only had 15 of our personnel getting afflicted with COVID, 9 of which have recovered. And the first 9 was during the first 2 to 3 weeks. So this was during March, and the entire April we were free. Unfortunately, we had a recent diagnosis of 6 employees in the past 2 weeks. And we kind of identified that they couldn't have gotten it from within the hospital, because the index cases for these 6, they go home to their communities. And I don't know if they're still practicing safety measures or if they're self-isolating. But so we think that they're getting it from the community and bringing it to us. Okay, so for monitoring of our healthcare worker in the clinical areas, we started getting baseline for our frontliners 2 weeks into the pandemic. Some of our medical personnel went on 1 week duty, 2 weeks off. So before they go back on duty, we screen them. But at any time, if symptoms are detected, then we do an immediate screening. Our personnel task force made a checklist, a daily checklist for all the divisions, for the division head to check the symptoms and the temperature of all the people in their area, and it is submitted every day. And by this method, we're able to detect one or two before their symptoms worsen. Remember, they're scared. Our personnel are scared, and sometimes they're not going to confess. They feel something. So by actively asking for their symptoms, we can catch their conditions early enough, diagnose them, isolate them, and treat if ever they get diagnosed. And for every index case, for every case that we detect, we trace all of the other personnel that they were in contact with, and then we also do screening for them. So where are we now? In terms of bed capacity, 1 month after the declaration of the lockdown, we have approximately 68 beds converted to COVID isolation bed. And as of now, we have about 89 COVID beds. So these are beds with exchange rate, air exchange that's acceptable. And half of that can be, we're already equipped for critical care. And we only have 40 beds for non-COVID. And this is our data, total of 2,415 seen or admitted for the past 65 days. Diagnosed COVID, 315. Probable COVID, 400. And of our diagnosed COVID cases, we have 129 recovered. Of the COVID, we have about 38 deaths, and the probable, we have about 40 deaths. So regardless of whether COVID or not, we have a mortality rate of about 12, 11. So so let me just show you. This is how many patients we see in the triage. Since we started, okay, I don't have the data for the early part, but in April 1, you will see that we have a total of 64. So this is our daily census. Our lowest is about 31. And lately, we've been getting a rise in the number of patients consulting our triage. COVID-related, initially, well, expectedly that it would be high. But lately, we're getting another surge for COVID consults. At the same time, we're noticing an increase in our non-COVID consults. As far as our admissions are concerned, for the 89 designated COVID, we have initially just 28. 8, and then it became at present. So I cannot see my slide. Tumataas na siya. Ang intubated number ng cases namin, presently we're at 16 or 17. And our suspects, since we have a gene expert already, for our inpatients, we get a diagnosis within 1 or 2 days. So we're able to either put them in the COVID census or transfer them to the non-COVID ward. But regardless, we're also noticing an increase in consultations of non-COVID cases. But initially, they all have COVID has to be ruled out for all our patients. So that's why we're getting this kind of picture. For the month of April, And 128 COVID patients, we had 29 deaths. So that's kind of high. But remember, we get only moderate to severe cases. The mild cases, we get to send them out to either QI or TALA or Hope 1 and Hope 2 quarantine areas in Quezon City. And for this COVID, we had 18% who needed intubation. And unfortunately, when they get intubated, our survival rate drops. Okay, so what are we doing right now? We're actually planning for 2 scenarios. We haven't demobilized. We're still preparing for that resurgence. We're preparing for the second wave. But if you can see our figures, we're not we've even done with our first wave. Tumataas pa yung aming TRIAGE consults, tumataas pa rin, or at least naka-steady yung aming census for COVID. So our isolation rooms currently were equipped to take care of at least 48 critically ill, intubated, ventilated patients, and we hope to increase that some more. Of course, we're asking for more personnel from the DOH for in case that we really go into this, that they will be giving us added personnel. And of course, we have to get our resources ready for the event. We have identified the triggers when we will activate our plans for the resurgence, and that is if we use at least 2/3 of the ventilators already, then we should start increasing our capacity for critically ill patients. So currently, 15 intubated, 40 designated ventilators were 37%. And so we need another 37% before we start panicking again. Okay? And the other is the scenario of the limited resumption of OPD and elective services. And so before we do that, we're evaluating the safety conditions of all clinical and non-clinical areas. So for all clinical areas, we're retrofitting the clinics and offices who will be accepting patients. We're making sure that for the patient areas or the clinical areas that there would be an adequate air ventilation or air exchange. We're considering getting UV lamps and HEPA filters to augment personal safety issues. We're also, I guess for most hospitals, we're shifting to this. We're going to be screening all patients online first using a COVID symptom checklist. For patients with a positive symptom on the checklist, which is majority of the patients that we get in lung center, they will have to have a swab done by appointment before they can be allowed a physical visit. So we will be requiring a COVID clearance for all symptomatic patients. So we are not yet here in this scenario because, like I said, we're still in the first wave and we haven't slowed down our preparations for the resurgence. But at the same time, we're beginning to retrofit all of these clinics, and we're targeting for June 15, assuming that we'll be in GCQ conditions by June 1. Then we'll observe if we go into a surge again when we resume GCQ conditions, but if not, then we'll be activating the demobilization plans and open by June 15. So that is our plan. So take home ko for all of you listening, the best way to take care of our patients is to take care of our health personnel. So bottom line is, if you cannot protect the healthcare workers and they get sick, then no matter what preparation you made for your hospital, or for your community, the whole system will just go down. So you have to take care of them. We can build ventilators, but we can't build healthcare workers. Keep them safe. Thank you.
So Dr. Eileen, thank you for that, for sharing your best practice. Truly innovation at its finest, given the limited resources that we have. So we move on to our third speaker, representing the private hospital, private sector. Let us welcome Dr. Benjamin Campomanes from St. Luke's Medical Center.
Hi, Debbie. Debbie, am I clear to you?
Yes, sir.
Yeah, okay.
Go ahead.
So let me just fix this one. Okay, thank you. So the topic given was best practices, and I put here that survived the test of time, because then we've had some practices that we had to shelve off because they didn't work very well, and trying to improve some outcomes for our COVID patients. So we will divide the lecture into the best practices according to one, the facilities and infrastructure changes that we had to do, patient care, healthcare workers' concerns, and then committees and other task groups that we had to put up for this crisis. So first, for the facilities and infrastructure, let's look at the emergency rooms, what happened there, the wards and the ICU beds, and the operating rooms. It is quite interesting that we saw patient number 4. We had originally 3 for the longest period of time, and then we saw patient number 4. And then after that, it never stopped after seeing patient number 4. So that was about the first week of March. So that on March 8th, we called what we called code yellow. Code yellow in the emergency room is seeing more than 20 infectious patients at one particular time. So obviously, we were the very first private hospital, and maybe one of the very few hospitals that were seeing a surge of COVID patients right away. And so at that point in time, we had to move our infrastructure and all our people. So the first one we did, of course, this is already best practice, is of course we separate COVID from non-COVID patients. So our emergency room, this is in Global City, can hold up to 7 critically ill patients at the same time. So we have 7 places like this where it's converted like an ICU already. And we have already in place 2 isolation rooms. And of course, we did telemedicine to minimize exposure to patients. We learned from our very first patient, which was patient number 4, because patient number 4 had contact with a nurse, a doctor, a med tech, somebody from cashier. So with that first patient, we learned our lesson right away. So at the emergency room in Quezon City, we did separation right away of our COVID and non-COVID patients. So we converted our chapel to a non-COVID ward. So the emergency room stayed as an emergency room for COVID patients. So in Quezon City, it's a smaller facility. We can hold up to 5 critical care beds. The other one in Global, we 7, and 24 of the suspects in the tents, which we put up immediately outside. So in Quezon City, we also had 2 existing isolation rooms. So we identified COVID wards. So in Global City, we identified total of 83 beds. So how did we choose the 83 beds? It's based on manpower, the infrastructure to be able to isolate the ward. We have to consider the ventilation and the air ducts in these wards so that they can truly be separated from everybody else. At the beginning of March, we already suspected that there's going to be a surge, and we bought all the available HEPA filters available in the Philippines at that time, I recall. The ICU allotment for Global City is based on our experience that 30% of our COVID ward bed patients will crash and will need to have ICU care. So therefore, we identified 18 ICU beds for the 83 ward beds that we have identified. And we needed, for the ICU, we had to hire intensivists because we wanted a 1:6 intensivist patient to doctor ratio. So for Quezon City, we have a total of 80 beds identified as a COVID ward. Again, as I mentioned earlier, based on certain criteria as to why we chose 80 beds. So about 30% of this would be 19. So there are 19 identified ICU beds. And again, we follow the 1:6 intensivist to patient ratio. So between the two hospitals, we are taking care of about 160 to 170 patients, COVID patients right away. So in the beginning in mid-March, all of these beds were full. So we were actually taking care of 15 to 20% of all the COVID patients in the entire Philippines at that time. I'm not saying that that's good, but we've had opportunities having had so many patients, both in our wards and our ICUs were all filled up. So this was both a problem for us and an opportunity in some ways that we can have a good number of patients to take care of. So our operating rooms also have been divided in COVID and non-COVID operating rooms. Fortunately, at Global City, we have a medical arts building operating room. We have 4 operating rooms there. So this has been converted to a totally COVID operating room area. And our main operating room on the 3rd floor has been maintained as a non-COVID operating room. In Quezon City, the CVOR or cardiovascular OR, which is 3 ORs, and 2 of them have negative pressure areas, are designated as COVID operating rooms, and the main operating room remains to be our non-COVID operating room. How about with patient care? So we will tackle 4 things here: the Quality and Patient Safety and Health Services Outcomes Committee. We have the COVID Scientific Committee and St. Luke's regular webinar series, and our Research and Biotechnology Division outputs. So for what we really have a Quality and Patient Safety and the HSOR team, and they were immediately tasked to gather and assist in critical decision making because data is very important. And as one example is, for example, immediately we asked our QPS, or Quality and Patient Safety, how many of these ward patients, because we were in the beginning we were really full, how many of these patients eventually will crash and go to the ICU? They determined it was about 30%, and that's why we allocated that much amount of ICU beds. Root cause analysis is done all the time for any healthcare worker infected for immediate rectification. And one of the first things that we did actually within a week of having all these people coming in was the creation of pathways and order sets based on best available evidence. So once the patient comes in for COVID, they're automatically given an order set, and this has been adapted in a lot of hospitals. We also formed the COVID Scientific Committee, and this has been, now there's about almost 800 members. And the reason for this is it becomes a platform to get our consultants updated on all related literature, reviewed, published, evidence-based, whatever it is. So there's a venue right away for all these, because we get all these questions from our consultants asking us if this guideline is true, if this paper is true, and all that stuff. So the COVID Scientific Committee now will wean out all insignificant, non-scientific based COVID-related guidelines and protocols. So I'm sure everywhere it's an issue wherein so many doctors have so many opinions and they want this certain thing done, and this is their opinion, this is what should be done, and if that's an issue, then we refer them all right away to the COVID Scientific Committee, where it's a venue where they will tell their opinion, and they will be either given an evidence-based guide or protocol. So this is a very good venue for questions and answers for medical questions regarding COVID, and I think this is a very nice practice that we do very well. We have regular webinars, and Debbie is one of them who organizes this, and we do it almost every week. We have 2 to 3 topics, and this is just a good example. And we've had several of these webinars already, and our platform for this is Google Meet, and we can only satisfy 250 participants at the same time. But some of these webinars we had to do several times because of requests from outside. We also have a very good research and biotech division, and we have facilitated all studies related to COVID. And in fact, last week, we came up with 3 published papers right away regarding our experiences with COVID. So how about with patient care? We've divided it into preparation and training of our medical staff. We're very interested in the CP program, teleconsult, and one of the things that we'd like to share is our pulse oximetry monitoring for our outpatient COVID diagnosed patients. So in preparation, during the first week of this pandemic, actually, we've already asked for volunteer internal medicine doctors, and they were given crash courses on critical care medicine and the use of ventilators, and several other training programs related to the COVID pandemic. So we also put up our convalescent therapy. Well, it's a program first, and what we did was we asked St. Luke's to fund it. So we were able to get funding for a minimum of 21 patients. So we've had 21 patients here. So this is completely funded by St. Luke's, and 21 patients were given convalescent plasma. We had 22 donors, 21 recipients. 14 of these were critically ill, 7 progressing to severe illness. And the outcome showed, of course, very safe to use, no untoward side effects. There were 10 were extubated from mechanical ventilator between 2 to 6 days post-CP, and 6 avoided intubation. So the conclusion to date for the 21 patients was CP should be given within 14 days. Convalescent plasma can prevent the progression of a respiratory symptom and prevent intubation. There are shorter ventilator days and ICU stays, and hopefully less hospital days and cost. And these are all comparable with other published studies on convalescent plasma. So, like everyone else, we try to promote teleconsult to everyone, and we regularly have teleconsult updates to inform the public of what departments and what institutes will have readily available to consults. And we have recommended and even required our residents and fellows to take up a free Harvard Medical School on a certificate on telephone and telemedicine in clinical medicine. And I think this is a very good practice. It's still free until June. So I think everyone should avail of this opportunity to get a certification from Harvard on telemedicine. Last May 20, we reopened our outpatient clinics. We've required all our consultants for RT-PCR tested before holding clinic as one of the requirements. And we've this is all for free for our consultants at St. Luke's Medical Center. Again, social distancing. We alternated the opening of clinics. And in the first or 2 weeks, we will limit our patient load to 6 patients per day. And these are all by appointment. There are very strict guidelines on appointments. And of course, like anyone else, triaging and patient flow. This was brought about by several articles and case presentations in New York, where they found out that the use of monitoring oxygenation can provide a warning that patient may need some O2 support. So with that, if we diagnose a mild case of COVID, then we let them take home a pulse oximeter, and there is a form. This is not the complete form, but the form includes monitoring of your pulse oximetry reading twice a day. And if your reading goes below 93%, then you have to go back to the emergency room right away. For our healthcare workers, which is very important, as Dr. Aniceto mentioned earlier. And what did we do for our healthcare workers? First, of course, we provide lodging and food, mobilization and protection of our staff. We did telemedicine. We gave compensation. We gave appreciation assistance programs. We had a care store program, which is our food and supermarket and for free. And of course, RT-PCR testing every 2 weeks for all our frontliners. So we rented a 100. This is in global. We rented a 180 bed building, and this it's called Cuarto, and 180 beds for those who have no place to stay. Then we give accommodations for them here. For the frontliners, some of our facilities, like our rehab centers, have been converted into dormitories and beds like this where they can stay. And we provide everyone, including our security guards, whoever is in the hospital, free food, breakfast, lunch, and dinner if you are on duty. For the mobilization and protection of our medical staff, to minimize the number of healthcare workers for a particular specialty, we ask them to go group practice so that only a few of the doctors, like let's say, for example, in pulmonary medicine, there are only 2 doctors who will make rounds in both COVID and non-COVID areas. And they go on duty every week so that there are very few doctors who are going to be exposed to COVID patients. Of course, like everyone else, we try to do telemedicine, and this is available to all the wards. You can just move the CCTV and you can get you can monitor the patients 24 hours. Also, which is a good practice, I think everyone should do this, is to save on PPEs. Like everyone else, even if we started very early on the first week of March, we placed our orders to different suppliers already, but most of them cannot deliver on their promise for those PPEs. So for our N95s, what we do is we process them by putting them in plastic bags like this. You put your name, and then we process them by STIRAD. STIRAD is a vaporized hydrogen peroxide machine. That's the principle behind it. And our infection control services and our quality patient care services said that we can reuse twice, but on the second use, you cannot use in aerosolized cases already. So at least, because now our use of N95 is, for you to know, is 1,500 pieces a day. So that's a lot of N95. So if we can use it twice, then that would be important. One of the reasons why it's soiled, because you can't put anything here that is soiled, is some of our women are still using lipsticks, which I think are not recommended anymore. Anyway, you're always with a mask, so there's no use in putting on lipsticks. How about compensation? For residents and fellows, the hazard benefits was based on the HR model for all our employees. And we gave appreciation honorarium to all consultants who rendered extra work beyond their normal duties. So we've also waived all our MAB and CHBC monthly and land rentals for March and April. We established soft loans in cooperation with an identified bank. So amortization free for 3 months and very, very small interest for a period of 2.5 years. And of course, we assist in telemedicine for most of our consultants. We provided a very generous gratuity honorarium for all our doctors in appreciation for their service. And we based it on a tier system where a tier 1 is the volunteer consultants in the hot zones, and tier 2 would have rendered extraordinary service on a daily basis since the inception of the crisis. And they are very generous honorarium. So these are all the doctors that we gave the envelopes to. So we also had a Care Store program. We offer free groceries to our frontliners, and this is done every week, once a week in Global City and once a week in Quezon City. So because some of our care workers have no opportunity to go to the grocery, so we give the groceries free for them. During the National Healthcare Workers Day, we also gave free shoes for all our frontliners in cooperation with ASICS. So other special committees will be the Donations Committee, the COPE, or the Caring for Others with Positivity and Encouragement, our Corporate Social Responsibility, and we will touch again on the free convalescent plasma treatment. So in the beginning, and I'm sure all of the other hospitals are awash with so many donations, and we had to put up a committee on this, log everyone so that we can thank. Some of the donations are monetary. It goes straight to our St. Luke's Foundation, and this is going to be tax-free. And most of the things that we give for free groceries have been donated by our very good and generous benefactors. For our COPE, again, the COPE is caring for others, and we mobilize our site team and HR the hashtag is we're better together, and that's what we did, and that's what we're still doing. We still have a lot of COVID patients in our wards and our ICUs. So with that, thank you very much for your kind attention.
Thank you, Dr. Campomanes, for that lecture. We just wanted to shout out to everybody who's in Facebook and in Zoom. We're broadcasting live all over the Philippines. And we have time for one or two questions, actually. Some of the questions were already answered by Dr. Baltasar through the chat, but just a point of clarification to Dr. Baltasar. After 2 negative PCRs, RT-PCR, do you still require 2 weeks of quarantine for your tested healthcare workers?
As prescribed, even in the civil service, once they are already cleared and clinically asymptomatic and feel well, they can go back to work. However, most of them, of course, they underwent anxiety, sleepless nights, waiting for their PCR results. So when they requested us to undergo further vacation and rest, we granted them.
Okay. So I think for Dr. Aniceto, can you tell us the status of lung center's testing capacity, given some reports of testing backlogs and delayed results?
Yes.
Dr. Aniceto?
Yeah, can you hear me?
Yes, ma'am.
Okay, because I don't think my video is showing. Anyway, we had a backlog of about 8,000 from from 2 months ago. Remember, there was a time RITM closed down, and there was a time PGH wasn't accepting any swabs, and Red Cross hasn't started its services, and the Philippine Genome also has limited. So we ended up receiving a lot of the swabs from all over. And we didn't have enough machines at the start, although donations started coming in. So now we're better equipped. We didn't have enough personnel, so we needed to get from DOH and other volunteers. So just to help in encoding. It's such a tedious process. Nakisawsaw na rin kami kung what's happening, kung bakit it takes that long. And for now, the good news is we're done with the 8,000 backlog. And for now, we're doing real time. So ibig sabihin, if you submit a swab, although we've established limits already. Like from every institution, limited to critically ill patients only. Because for a while, hospitals outside were doing mass testing of their employees, sending it to us, and we cannot even do the mass testing on ourselves because we're being swamped with all of the requests from outside. So there were just too many requests for the swab. But the good news is we're caught up, and so real time now. Once we get your specimens, it will take between 4 to 5 days if we do the RT-PCR. Then we have another way of diagnosing using the Gene Expert Express, the SARS-CoV-2 Gene Expert, and that although it meron siyang additional na fee, will get you your results within 24 to 48 hours.
Okay, that's good to hear, ma'am. Another question, I think they saw the plastic separators.
Mm-hmm.
So how do you disinfect the plastic separators so as not to affect clarity?
Well, it should be taken down and replaced every so often. For now, we do the misting. What's it called? A mild bleaching solution, and we spray mist on plastic.
Okay. I think Dr. Campomanes was cut off, but he told me, I texted the question to him and then he answered it. for SLMC, was there any outbreak that happened in the accommodation facilities for your healthcare workers? If so, how did you handle it? So none so far. The outbreak were in clusters where they eat together. During the first month in March or April, most of the healthcare workers were eating together. So they found out that there were outbreaks there because they would remove their mask and bring down their guard. And once they were educated about it, then it was controlled after that. For all speakers, how long do your residents, fellows rotate in the... Dr. Campomanes is already in. So I've answered the outbreak, sir, already. For all speakers, how long do your residents, fellows rotate in the COVID ward? And how long do you put them in quarantine? And the follow-up question, another question is, do you have your own quarantine facility? So we start with Dr. Glory, and then Aniceto, and then Dr. Campomanes.
In our setting, our residents and other consultants who go in the COVID ward and isolation rooms for 7 days, and then they will quarantine for 14 days. Or as long as the result of their, if there's a breach in the, they know that there's a breach in the PPE protocol, they have to be swabbed and wait for the result of their test.
How about you, Dr. Aniceto? Is it the same?
For the pulmo medical staff, we go on rotation, so 1 week. Like currently, I'm on duty, and our duty will end by Monday. So, and then we go on quarantine for 2 weeks. Unfortunately, because I'm in operations, those of us in operation continue to work every day. For our fellows, we don't have residents. They're on skeleton force. Separate the fellows going on duty in the non-COVID is separate from those who are going on duty in the COVID wards, and they have separate columns or quarters. But the most that we can give them is skeleton force. They can't really do the 2 weeks off because they're in training. So, and like Dr. Campomanes, we also do Zoom lectures and online webinars for them. So yeah, the most that protection we give our fellows is that they're on skeleton force. So they go on duty every 3 days in the ward that they're assigned, and then they just make rounds in the morning.
Dr. Campomanes?
Yes. In the big departments and units, we don't allow our residents and fellows to make rounds in the COVID wards. They are protected from that. Unless necessary, they will stay in the non-COVID wards.
As a follow-up question, can you comment on the scheduling of your nurses? Is it also the same as the doctor residents? 7 weeks on for Bataan and then 14 weeks off?
Yes, we do the same.
Same for nurses. How about lung center po?
Unfortunately, we don't have enough nurses to do that. We're trying to maintain 1:6 patient ratio. Remember, we're getting moderate to severe cases. Yes. And so, yeah, we couldn't do that for our nurses. Pero separate yung mga from COVID. So we try to just isolate the areas and the shelters of the nurses concerned.
Yeah,
for St. Luke's, sir?
We're the same with lung center. We don't have enough manpower to do that.
For St. Luke's, clarification for Dr. Campomanes, RT-PCR testing of doctors, will this be a one-time test or recurrent to allow them to see patients or practice? Is it mandatory or optional? Yes,
for the first for the first testing, it is mandatory for our consultants to have an RT-PCR, and we use this as a baseline. Several things may happen within a 2-3 week period. There may be a validation of a rapid antibody test, which is a possibility. We also have a gene expert where our system, we can test within a 45-minute period. We will know the results. So as of now, we just test baseline. So all our doctors are tested with RT-PCR baseline, and we offer that for free. The subsequent testing, we are looking at the possibility of just a rapid testing that is validated by RITM and DOH. But we'll go along and play it by ear, because we're ordering some very good testing system. Of course, this is depending on DOH or FDA will approve us of testing kits or testing ways where it's going to be very fast, very accurate, and very short. But as of now, we test all our doctors with RT-PCR, and if the validated ones of the rapid antibody test validated kits will come out within that period of time, then we may just monitor with that one together with very strict surveillance by history.
So I think we have time for one last question. Can you explain further? Anybody can answer this if you're doing it. Can you explain further the sterilization of N95? Repurposing and re-sterilizing N95. What is the evidence in support of this?
The CDC recommendations is really for, because we have steroids, which, as I said, hydrogen peroxide based. So we can reuse as long as it's not soiled. Then you can reuse once. If you steroid an N95, you can use it for a non-aerosolized procedure. So if you're going to have an aerosolized procedure, you will need a new N95. Again, I have to make clear that all N95s are not created equal, not because they are all N95s. It's the fitting which is very important, because you can have a good N95, very good, CDC, NIOSH certified, but the fitting is not good, it's useless. So that's why we have a hard time that a lot of people donate a lot of very good N95s. They're all large, and all our nurses have small faces. They are useless for our healthcare workers that have very small faces.
Okay, so I think this is a personal question to Bataan General and Lung Center. Given that you have a lot of COVID cases, and we see that non-COVID cases are also increasing. You said that you'll wait until June 25, but in the meantime, in the interim, because pre-COVID, you had a lot of cases that are non-COVID. So where do these patients go to? Do you have partner hospitals where these patients are being seen or accommodated? Dr. Baltazar or Dr. Aniceto can answer the question.
Yeah, in our province, because of the our setup, our hospital is really not designed to have a commingling of cases for infection. As I've shown in my presentation a while ago, there is always a possibility of cross-contamination unless you put all your infectious diseases cases in a separate building. So I requested support from the local government, and they were generous enough to quickly renovate their old Capitol building, which is now intended for a museum. They are renovating it. We're just awaiting for its full usage by first week of June. So we're going to put up a 50-bed for non-COVID cases. Meanwhile, we are a dedicated, in the meantime, we are a dedicated COVID facility.
For Lang
Dr.
Sen,
Eileen.
yes. We have a hotline. We have a COVID hotline, which the patients, our service patients call for instructions. And there's a way that we can send their prescription. So it's a little more on telemedicine, and then they can access our consultants are on duty in the hotline for questions regarding non-COVID concerns. Yes.
For St. Luke, sir, you're slowly transitioning.
Yeah, we're of course we're looking at our non-COVID. We have separated adequately and well our COVID from non-COVID. So we're starting to open up all our clinics and all ancillary services and our operating rooms.
So in the interest of time, we'd like to congratulate all of our speakers for very wonderful lectures. For all of our participants, this webinar will be recorded and it can be accessed through Facebook, through the Facebook of the Philippine College of Physicians and the Facebook of the Department of Health. Join us again for another webinar on Monday, although it's a holiday. The topic of our webinar is the real score on contact tracing and testing in the Philippines. It's on May 25, which is a holiday at 10 a.m. We'd like to thank everybody who have watched us, and we would like to congratulate all of our speakers. Thank you and have a good day.